When you hear medical miracle, what comes to mind for you? Spontaneous recovery, maybe?
Maybe some breakthrough drug, yeah.
Right. But what about something we almost, well, take for granted now, like organ transplantation?
Ah, yes, definitely up there.
It really is one of humanity's most incredible medical achievements. I mean, a real testament to innovation, surgical skill.
Absolutely.
But what looks like a routine, life-saving thing today, it's actually built on, well, a whole century of struggle, failures, and these brilliant leaps forward.
It really is.
So our mission for this deep dive is to explore that journey, the whole fascinating century-long story of kidney transplantation. We're going to trace it from the very earliest, kind of surprising experiments right up to the robotic procedures we see now.
Yeah, the cutting edge stuff.
We've looked at a stack of sources to, uncover the key moments, the big discoveries, the surgical breakthroughs that made it happen. You might be surprised how small steps paved the way.
And it's not just about the medicine, is it? It's a story of, well, sheer perseverance, ingenuity.
Yeah. And really getting to grips with these incredibly complex biological barriers. We're going to unravel how surgeons, scientists, how they tackled huge challenges, like rejection,
The body attacking the new organ.
Exactly. And preserving the organ itself. Turning this once unimaginable idea into a standard life-saving treatment worldwide. It's really a story of solving problems one by one.
Okay, let's unpack this journey then. To really get where we are now, we have to start right at the beginning.
Makes sense.
And it wasn't exactly a success story, first off, but foundational. Think late 1800s, 1896.
Okay.
A French surgeon, Jaboulay, and his team, they were doing pioneering work in vascular surgery on blood vessels.
Right, the plumbing.
Kind of, yeah.
Yeah.
They were figuring out how to suture, stitch blood vessels together.
Yeah.
It sounds basic now, maybe.
But crucial.
Absolutely crucial groundwork, creating the very first techniques needed for any transplant later on. You can't connect an organ without connecting its blood supply.
And what's really amazing is how quickly Jaboulay then pushed that boundary.
Well, just a decade later, 1906, he performed the first human kidney xenotransplants. Meaning with a different species. He grafted pig and goat kidneys into human patients.
Wow. That's bold for 1906.
Incredibly bold. You can imagine the hope, maybe desperation driving that. And, well, the outcome was fleeting.
It didn't work.
Urine was produced, briefly, which must have seemed like a huge sign of success for a moment.
Yeah, I bet.
But the grafts failed within 3 days. Mostly thrombosis, blood clots blocking things up, and as we now understand, massive rejection. The immune system just went haywire against the animal tissue.
So a failure, but a telling one.
Exactly. It highlights that sometimes the biggest leaps come from understanding why things fail, even if the reason isn't totally clear right away.
And learning from that failure, or at least from Jaboulay's work, was Alexis Carrel.
Ah, yes. Nobel laureate Carrel.
He won the Nobel in 1912, right, for vascular suturing work. He took those early techniques and really perfected them. Crucial end-to-end vascular anastomosis methods.
Anastomosis, just meaning the surgical connection, joining two tubes like blood vessels.
Right, and think about it. These techniques, developed decades before any real human transplant success, they become absolutely vital later on.
It shows how foundational research works, like inventing the perfect bolt years before you know what bridge it's going to hold together.
So summing up that pre-1950s era.
A lot of effort, lots of animal experiments, Ullman's dog studies, things like that. And unfortunately, many failed human attempts too. Shows dedication, but also just how big the scientific gap still was.
They knew what they wanted.
But not how to beat the body's defenses. Not yet.
Which brings us to where it gets really interesting. Fast forward. December 23rd, 1954, Peter Bent Brigham Hospital in Boston.
The big moment.
That's when Joseph Murray, J. Hartwell Harrison, their team, they performed what's seen as the first truly successful human kidney transplant. You can almost feel the tension in that OR.
So the big question is, why this one? Why did it succeed after so many failures?
The donor.
Exactly. The key was the recipient and donor were identical twin brothers.
Ah, the perfect genetic match.
Precisely. It naturally sidestepped that huge hurdle of immune rejection. The body saw the kidney itself.
So the surgery itself.
It was still a big open operation, took about 5 hours. But the outcome was amazing for the time. The recipient, Richard Herrick, lived for 8 more years with that kidney.
8 years.
Incredible.
And it wasn't just about saving one life. It was proof. Proof that organ transplantation could work. It shifted the focus, didn't it? from if to how.
How do we make this work for people who aren't identical twins?
That was the immediate next challenge. Murray's team, others too, like Kuss and Hamburger in Paris, they started looking into transplants between non-identical donors.
So if the immune system was the known enemy now,
Yeah.
what was the next step? Better matching or something else?
This is where the real modern era kicks off, April 5th, 1962.
Okay.
Murray again. He performs the first successful cadaveric transplant.
Meaning from an unrelated deceased donor. Correct. And the game changer wasn't the match this time. It was pharmacology. Drugs.
Immunosuppressants.
Yes. Azathioprine and steroids. The first drugs used to actively suppress the recipient's immune system to stop it attacking the new kidney.
And did it work?
That's the spot. Access through a curved incision, the Gibson incision. A big cut down the middle was rare, only for really specific access needs. And the connections, the plumbing part.
Yeah, how did they hook it up?
Pretty precisely. The donor renal artery and vein, the kidney's main vessels, were sewn directly onto the recipient's iliac vessels, those big ones in the pelvis going down to the leg.
How exactly?
Usually indocide anastomosis. Think of it like T-junctioning a smaller hose onto the side of a bigger pipe. Donor artery to external iliac artery, donor vein to external iliac vein, ensures good flow.
Makes sense. And the ureter, the tube draining urine.
That was another challenge. Early on, they used the Ledbetter-Policano technique, tunneling the ureter inside the bladder. But it was tricky, technically demanding.
Prone to problems.
Could be. So by the 1970s, a simpler method became standard. The extravesical, or Lich Gregoire, technique.
Extravesical meaning outside the bladder lining.
Right. You implant the ureter into the bladder wall without fully opening the bladder, created a sort of tunnel in the muscle, fewer complications like leaks. That became the go-to.
Wow, that's a lot of intricate surgical work. But as transplants expanded, moving beyond just a few centers, there was another issue, right? Logistics.
Absolutely. Organ preservation. How do you keep that donor kidney healthy while it's being transported? Maybe across the state or even further, that became critical.
So what was the solution?
Cold. Cold perfusion methods started developing in the 60s and 70s.
How did that work?
Kidneys were flushed with coal, like 4 degrees Celsius, cold preservation solutions, then stored on ice. The cold just dramatically slows down metabolism, hits the pause button, basically.
So it has time.
Exactly. But the huge breakthrough was in 1969. Folkert Belzer and James Southard at the University of Wisconsin. They formulated the UW cold storage solution.
Ah, the Wisconsin solution. Still hear about that.
It became the gold standard, radically extended how long a kidney could stay viable outside the body, from maybe a few hours to over a day, sometimes longer.
That must have changed everything for matching and allocation.
Massive impact. Suddenly, organs could travel regionally, naturally sometimes, expanded the donor pool hugely. Later, we got pulsatile perfusion machines, too.
Pumping cold solution through.
Yeah, gently pumping it through, especially for maybe marginal kidneys, from older donors, perhaps. Helps assess them, reduce injury. And now there's even normothermic machine perfusion being explored.
Normothermic.
Body temperature.
Exactly. Perfusing the organ at body temp before transplant lets you really test it, maybe even recondition a high-risk kidney, like a pre-transplant checkup for the organ itself.
That's incredible. Such huge leaps in just getting the organ ready. So let's shift to the patient experience today, the surgery itself. Starting in the 90s, things really changed with minimally invasive approaches, right? Especially for donors.
Oh, absolutely revolutionized donor surgery. The landmark was 1995. Lloyd Ratner and his team at Johns Hopkins.
What did they do?
The first laparoscopic living donor nephrectomy.
Keyhole surgery, right? Tiny camera, specialized instruments through small ports in the abdomen. Then they'd retrieve the kidney through a slightly larger but still small Fanon-style incision. Low down, the bikini cut.
And the impact for the donor.
Night and day.
Yeah.
Much faster recovery, way less pain, tiny scars compared to the old open surgery. It just took off. Cleveland Clinic adopted it by '97. It became the standard almost overnight, and it continued to evolve. Hand-assisted laparoscopy, single port. Most living donors now have one of these minimally invasive procedures. It's made donation much less daunting.
That's fantastic for donors, making that gift easier. But the recipient side, applying minimally invasive techniques there to someone who's ill, getting a new organ, that sounds much tougher.
It definitely was a bigger challenge. Surgeons did explore it, though. The first completely laparoscopic kidney transplant connecting everything with scopes was reported in 2009 by a Spanish team.
But it didn't become common practice.
No, it never really caught on widely. The big sticking point was the suturing. trying to precisely sew those delicate blood vessels together using laparoscopic instruments. Looking at a 2D screen, extremely difficult.
Like tying knots with chopsticks on TV, you said?
Something like that. Precision is everything there. And that limitation, that difficulty, really paved the way for the next big leap.
Which brings us to the robots.
Exactly. Surgical robots. In 2001, a French team, Hosneck and colleagues, performed the first robot-assisted kidney transplant.
What did the robot offer that laparoscopy didn't? Why was it the game changer?
It solved the key problems. First, the vision. Robots offer high-definition, 3D vision. You feel like you're right there.
More immersive.
Much more. And second, the instruments. They're wristed. They mimic the human hand's dexterity, but scaled down, tremor-filtered.
So you get that fine control back.
Precisely. It allows for incredibly accurate, tremor-free suturing for those crucial vessel connections, the anastomoses, and also for implanting the ureter. The surgeon sits at a console, controlling these tiny, precise robotic arms inside the patient.
You mentioned Cleveland Clinic's program expanding rapidly.
Yeah, it's a great example. Over 60 robotic transplants in 2024 already, almost a third of their total volume. And they did that innovative first single-port robotic transplant back in 2019.
Single port. Just one small incision for everything.
Well, one main small incision for the robot port and kidney insertion, plus maybe a couple of tiny assistant ports, but yeah, incredibly minimally invasive.
So walk me through it. What does a typical robotic transplant look like from the surgeon's and patient's perspective now?
Okay, so the robot procedure basically follows the same principles as open surgery, but through these small access points. It usually starts with that low Pfannenstiel incision again, maybe a bit bigger, to place a special gel port.
For getting the kidney in.
Exactly. Then several small 8 to 12 millimeter robotic trocars. The tubes for the instruments are placed above it. Robot docks, surgeon sits at the console.
And then the connections.
Meticulously done with the robot. Donor renal vein sewn into side to the recipient's external iliac vein. Donor artery to external iliac artery. Then, after blood flow is restored,
the kidney pinks up.
Right. Then the ureter, often with a temporary protective stent inside it, is carefully tunneled into the bladder and sewn in place using that same Lich-Gregoire extravesical technique.
The same technique as open, but done robotically.
Correct. The robot's magnification and those articulating instruments make these complex steps feasible through tiny ports. And the benefits for the patient: less blood loss, quicker recovery, less pain, getting them home and back to life sooner.
It's incredible. So looking back over this whole century, it really feels like the core ideas, the principles of the surgery have stayed pretty constant, even while the tools and techniques have just transformed.
You've hit it exactly. It's this fascinating mix of continuity and really radical change. Take the incisions.
Yeah.
We went from that big Gibson curve, or sometimes a midline cut, to tiny keyhole or robotic ports, maybe with just that small Pfannenstiel cut to get the kidney in or out. The way we get there is totally different, but the destination, putting the kidney in that iliac fossa spot, is the same.
And the vessel connections, still fundamentally the same idea.
Pretty much. That end-to-side connection of the kidney's vessels to the iliac vessels is still the standard. Renal artery to external iliac artery, renal vein to external iliac vein.
But refinements.
Oh, definitely. Like the Carroll patch technique you sometimes use if the donor kidney has multiple arteries. Instead of sewing two tiny arteries separately, you take a small patch of the donor's aorta with both arteries coming off it and sew that patch to the recipient's artery. One connection instead of two tricky ones.
Clever simplification.
And the suture materials themselves are so much better now. Super fine, strong, non-absorbable threads like 5-year or 7-0 gauge, thinner than hair for a secure, leak-proof seal.
And the ureter connection, you mentioned the shift there too.
Right, from that older, trickier intravesical tunnel, the polytunnel Ledbetter, to the now standard extravesical Lich method. Sewing the ureter to the bladder, lining through that small muscle tunnel from the outside, avoids fully opening the bladder.
Less invasive, fewer problems.
Exactly. And often a stent is placed temporarily inside the ureter connection just to ensure good drainage while it heals. And importantly, that same Lich principle is used in the robotic cases too. It's just proven itself as the best approach over time.
So today's transplant surgery really stands on the shoulders of giants, doesn't it? A century of innovation in anatomy, understanding the immune system, developing technology.
Absolutely.
And it's still evolving. Better perfusion machines, more advanced robots. Outcomes just keep getting better. We really owe so much to pioneers like Murray, Belzer, Ratner, and the centers like Cleveland Clinic, Johns Hopkins that keep pushing those boundaries.
It's truly a massive collaborative effort over generations.
This deep dive really paints a picture of the sheer scale of that journey. I mean, starting with failed pig-to-human grafts in 1906.
And learning from those failures.
All the way to single-port robotic surgery just a few years ago. It hammers home that medical progress isn't usually one big eureka moment, is it?
Rarely. It's almost always a continuous buildup. Small, precise innovations, one on top of the other, driven by persistence, by sharing knowledge, collaborating across the world.
And it makes you wonder what seemingly small, maybe technical innovations happening right now in any field are laying the groundwork for the next century's miracles. Things we can't even imagine yet. It's a powerful reminder, isn't it? Foundational work, incremental steps, that's how you build these extraordinary futures. Makes you think what unimaginable breakthroughs might be seeded by today's small advances.